Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Khalil Ekalona, and this is Nashville. In 1985, Tennessee reported 25 cases of AIDS to the CDC. At the time, there was a lot of misinformation attached to the disease. Many believed that it only affected gay men or drug users. This mistaken belief just allowed the disease to spread more quickly, and the social stigma around HIV and AIDS only perpetuated the neglect of those already infected. But here in Middle Tennessee, a group of dedicated people organized to spread awareness, and it helped save lives as a result. Later this hour, we'll learn more about the history of AIDS in our region from people who have provided services, education, and support to those in need. But first, yesterday, the Tennessee Lookout reported that the Department of Children's Services has been unnecessarily placing children in its custody in hospitals, sometimes for months at a time. The embattled agency has come under scrutiny for its treatment of kids in its care, staff shortages, and lack of transparency. Joining me now to help unpack this is Anita Wadhwani, senior reporter at the Tennessee Lookout, who broke the story. Hey, Anita, welcome back to This Is Nashville.
Thanks for having me again.
Pleasure to have you with us. All right, so give us some background on this story. How did you discover that kids are being unnecessarily hospitalized by DCS?
Well, I guess I wanted to start by saying that I can't really emphasize strongly enough the level of crisis facing this Tennessee's Child Welfare Agency. And it's a crisis that affects children on an everyday basis. The DCS's responsibility is to protect children who've been subject to abuse and neglect, often taking them from those abusive homes and finding safe and caring places for them to be. And right now, it is abjectly failing to do that. And that is impacting real children in Tennessee every single day. Mm-hmm. So in terms of the hospitalization of kids, I guess I would rewind back to last summer, the summer of 2021, when we reported that some children were sleeping in state office buildings. We obtained a video secretly shot by a caseworker that showed kids lying on the floor without mattresses, pillows, or blankets. And we learned that DCS simply did not have places to put them. They didn't have appropriate foster homes. They also didn't have treatment centers for kids who maybe needed medical, substance abuse, other kinds of treatment. And some of the kids, are taken into homes in the middle, or taken from their homes in the middle of the night, and need an emergency place to sleep. Since then,
No, continue. I'm sorry.
Well, since then, you all, Channel 5, the Tennessean, has continued to report on the fact that kids are sleeping in state office buildings because there is no place else to put them. And then earlier this month, at a budget hearing where the agency's new commissioner, Margie Quinn, she's been on the job since September, mentioned that in some instances, kids who are too disruptive when they're sleeping on those office floors are being taken to hospitals. So I was really curious about that. I asked DCS a bunch of questions I haven't gotten, that haven't fully been answered. But what I was able to learn is that there are children who do not need hospital care, who are being hospitalized, DCS says, between 1 and 264 days because there is simply no place else to put them.
Have you been able to discover how many kids have been in this type of situation?
That is a question that DCS has not provided an answer to, and that question's been outstanding for several weeks.
All right, so we've got kids who have no medical reason to be hospitalized and some who need to have medical care. Tell me, what have you learned about the kids who require treatment and their placements?
If you're talking about the hospitalized kids, Khalil, is that what you're asking?
Yeah.
So it's not clear that those kids require treatment. What I have been told by DCS, which I will just say has a lot on their plate. They no longer have communications staff whose job it would be to answer reporters' questions. And the person who's trying to answer my question has a complete other job. But what he has been able to tell me is that the kids who are winding up in hospitals, some of them are older kids who are in wheelchairs. Some are kids with tracheostomies. Neither of those situations precludes a child from being in a home, but they are trickier to place. So, for example, you would need a foster home that was wheelchair accessible, or you would need a foster parent who is trained at cleaning a tracheostomy care. So that is definitely a challenge, but it's not clear to me that they're getting any, medical treatment in these hospitals. That's not why they're there. They're there because the agency is unable to find more suitable placements.
What about education? I mean, are these kids going to school at all?
So I did ask DCS that question. What they told me is that their education is the responsibility of the child's original school district. They weren't specific about whether the school districts were meeting that responsibility. And I think what that would look like would be remote learning. And for kids who didn't have a school for whatever reason, it would be DCS's responsibility to provide that education. So I know what DCS says it's supposed to look like. It's not entirely clear to me what in practice is actually happening with these kids' education. And, I'll just go back and reemphasize that the upper range so far of how long a child has been in a hospital is 264 days. That's almost 9 months. That's almost the entire length of a school year. So that's quite a long time to not have like a stable educational system in place.
You mentioned DCS's new commissioner, Margie Quinn. What has she said about all of this?
Well, she said publicly in, for example, in that budget hearing, she talked about she didn't use the word crisis. I will, because I think that's clear, but she talked about what a terrible situation she had stepped into as new commissioner in September. DCS has almost 500 vacancies in social workers, and these are the hands-on people who are meeting with these children, figuring out what their needs are, and finding them appropriate care. Among first-year social workers, this would be their first year on the job, the turnover is 50%. So half of all people leave before they get to the end of their first year on the job. Their caseloads for the caseworkers who are still there are double and triple what they should be. I've heard various numbers, but some are handling nearly 60 cases where the standard should be around 20. And she also said that, for kids who need residential treatment, and again, that's, a kid who might have substance abuse, has mental health care needs for other reasons. She said during the budget hearing that there are enough beds in Tennessee. These are facilities mostly operated by private providers, and there are enough beds for every kid who needs one. but DCS doesn't pay the rates that these providers are charging. And so these beds are going to kids who, private insurance is paying. In some cases, child welfare agencies in other states are putting their kids with needs in these Tennessee facilities.
How has Governor Lee responded to all this news?
He said a couple of different things. One thing he said was he used the word immediate, or this needs to be taken care of immediately. And one solution that I believe they're moving towards is privatizing some social work. So hiring agencies, nonprofit, for-profit agencies who would bring that kind of social worker force to the frontline force to begin to care for these kids. But just kind of looking really carefully at what he said, it's not clear to me that would be put in place immediately. That appears to be part of the over $150 million that DCS is requesting for next year's budget, which, that budget doesn't even begin till July. That's when the money comes in the bank. So you wouldn't get that underway, even till much later after that. And I might be wrong, but this is just what's been said publicly. He's also urged DCS to be really transparent about what's going on. I frankly have not seen that to be the case. I think it's very hard for advocates, for journalists, for people who really want to understand not only what's going on inside DCS, but how we got here, to have a clear picture.
Anita Wadhwani is senior reporter for the Tennessee Lookout. You can find her story on this episode's post at thisisnashville.org. Anita, thanks again for being here, and thanks as always for your reporting.
Thank you.
We have to take a short break. When we come back, we'll explore how the AIDS epidemic impacted Middle Tennessee. Have you or someone you know been affected by AIDS? Join the conversation. Tweet us at This Is Nashville. We'll be right back.
Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Khalil Ekalona, and this is Nashville. In 1985, Tennessee reported 26 cases of AIDS to the CDC, but infections were already aggressively spreading in larger cities. And here in Nashville, a group of volunteers recognized the looming crisis, so they began a grassroots effort to address the growing AIDS epidemic in the region. Later that year, they formed the nonprofit Nashville CARES. Since that time, they've been spreading awareness and offering services to people who are infected. My next guest was head of Nashville CARES for 25 years. Dr. Joseph Interante, thanks for being here and welcome to This Is Nashville.
Great to be here.
Great to have you with us. So, Nashville CARES has been around nearly a decade by the time you were hired in 1994.
8 years.
8 years. What was the state of HIV and AIDS in Nashville and in Middle Tennessee at that time?
In 94 when I got here? Well, it had been steadily growing in terms of numbers. I would say that I was surprised when I came down here, and that reflected my own Yankee biases, prejudices, that the community, I thought, was engaged more proactively around HIV than what I was used to in Ohio. And I think the reasons for that were that there was some civic and political leadership that had been affected on a personal level by employees who had died of AIDS, who responded positively and went beyond that to then move beyond the boundaries of their institutions into the community to begin to build a community response to HIV. And so you had companies like Ingram Industries, to give them credit. Bill Bredesen, as mayor, had a task force that was working on building an outpatient medical clinic that could avoid the overwhelming and overcrowding in emergency rooms in hospitals that had been occurring on the coast. There was a public-private partnership that began to draw significant funding called the Community AIDS Partnership that was managed through United Way to build prevention and direct services. So that's the positive side. The negative side is you're still dealing with a disease for which there are no really known treatments, certainly no cure, no vaccine. And stigma is significant. And the fear that people experience about what will happen to me, my loved ones, if people find out that I'm living with this disease was pretty pervasive. So that, and people still, for the most part, were finding out that they had this disease when they started to get sick. So that in those early days, I think one of the important things that CARES provided was an effort to make sure that people knew that they were loved and they were not alone, and to provide them with an opportunity to die with dignity.
How about Nashville CARES at that time? I mean, what condition was it in when you got started at the organization?
Well, it was much smaller, both in terms of numbers, in terms of funding, in terms of programs. Some of the important material support programs, the housing assistance programs, the food pantry, things like that, transportation were virtually non-existent because of a lack of funding to provide support for those. I will say that it was going through the growing pains that comparable organizations around the country were dealing with. A small staff, sort of a bit internally disorganized, at times dysfunctional, and a transition which is never easy, in which volunteers, which was entirely what the organization was when it started, began to realize that the work was so large that they couldn't do it exclusively by volunteers, and so they began to turn over some of those responsibilities to staff. To do that effectively, you've got to have a level of trust. That doesn't happen automatically. So that all of the growing pains involved in building relationships of trust and knowing that the people you hire are going to deal responsibly and with accountability doesn't happen overnight.
One thing that you all did was grow that responsibility and accountability to really open up programs. You spread awareness about HIV and AIDS, but you also increased access to testing during that time and since.
Right.
Why was that so important at the time?
Well, it was important because that provided people with the basis for being able to decide, what courses of action. The first step in taking charge and control over managing this disease in your body, and I speak as somebody who was found out he was HIV positive in 1985, is to, in fact, find that out for sure. And that allows you to begin to take steps to link into areas of support. There were a number of concerns and uncertainties about the tests. And so, CARES began to try to bring testing out into community locations. Initially, it was where we would go and set up events, bring in personnel from the local health department who would do what were essentially blood draws because it was a blood-based test. And I'm trying to think, what year did oral testing come in? Do you remember, Dwayne?
99.
99, okay. That was really a sea change because it then allowed us independently to bring testing out into a whole bunch of different locales. And even initially, when it still took a week or more to get results. One of the things that I think was of note is that we always had very good follow-up. We did not have a significant problem in people not coming back for test results.
Okay.
And I think the reason for that was because people trusted us, which was the whole point of having an organization like CARES do this, to avoid the questions around, what's going to happen to this information? Who's going to get it? What do I do around these sorts of things? And I will also say that to the credit of the state health department, they were extraordinarily serious about preserving the confidentiality of that information. They never used it for any other purposes than for some planning around public health needs. And that's to their credit because that didn't happen everywhere.
Yeah. Now, at the time, the disease was thought only to affect gay men and people who used drugs. But there were racial disparities as well. What led to such disproportionate numbers among African Americans and other minorities at the time?
Disproportionate numbers as such. Well, I think one of the things I think that needs to be made clear is that if you're talking about the impact within African American communities, you also need to acknowledge that a significant number of the people in the African Americans who were impacted by HIV were from the beginning and continue to be Black, gay, and bisexual men. As in the white community, it was gay and bisexual men. So it was, the irony is that AIDS has always been a gay disease and not a gay disease at the same time. Gay and bisexual men were always disproportionately impacted regardless of racial background. It's although the other thing that I would simply add is that women were always impacted from the beginning of the disease. Initially, from the statistics, they were mainly, it was through intravenous drug use or partners of drug use as such. And I remember, it was only a few years into the epidemic when they realized, in fact, that despite initial beliefs, this was a disease that was also transmitted through heterosexual activity as well. And so that became a significant source of infections among women as well.
If you're just tuning in, this is Nashville, and I'm your host, Khalil Ekalona. We're talking this hour about the history of AIDS and HIV in Middle Tennessee. Now, my next guest helped spread the word about AIDS in the African-American community. Dwayne Jenkins is the GLBT Prevention and Education Services Director at Nashville CARES. Dwayne, thanks for being with us.
Thank you for having us.
So you started the first AIDS education and support program for Black men in the city, known as Brothers United. How were you able to break through some of the racial barriers of AIDS education and outreach here in Nashville at that time?
I think one of the great things about me moving from New York, coming to Nashville, and then right as Joe came on board, started as a volunteer. And so with my volunteerism, I saw that there was a need. And then I was in the right place at the right time because I was always going to the jails and prisons doing prevention programs with one of the coordinators. And at that point, the trajectory of people living with HIV had really turned Black and brown, we could see. And so Joe at the time and the other education director said, we need to do a focus group and let's see, what we can do. And I was part of that original focus group. And then once we developed the name and everything went really quickly at the time, we just went out, and that was to the benefit of Joe and Nashville CARES. They were like, let's get in the community. We weren't looking for funding. It was just a volunteer group, a volunteer organization coming to support. So at the times, we went to the clubs, we went to the churches, we had all of these different things, but we just went out there. We got what we needed from CARES, and this is before testing. So condoms, literature, and all of that. But it was what we were welcome. And one of the great things that was, I think, a little bit different about being an outsider was that there was no pressure on the people who lived here. No one knew my face, so I was like, okay, can you welcome me? Can we come on in? And And so there wasn't that kind of a pressure. So the doors were open. There were things happening, like with Reverend Sanders and everything. So we were able to get in and do the things that we needed to do and partner, as Joe mentioned, even with the health department and all of that. We had those events, and they were good enough to come out and do the testing with us in partnership.
You say you all were welcome, but I'm sure that there were misconceptions that you were battling at the same time. And from what I understand, despite all your efforts, you had a really tough time reaching African-American women during then.
Absolutely.
Why do you think that was?
Well, at first, again, the focus was Black and gay men, so same gender loving men. And so what we started to do is we realized that the numbers were also increasing within women. And so we would have to ask either our lesbian sisters or our cisgendered heterosexual sisters, like, hey, could you come to this event? It's not just a gay event at the club. It's not just this. And they had to really open their eyes. And because a lot of the, let's say, the programmings may have been at the time in LGBTQ spaces, we had to get them sort of okay to do that. But then we also had the issue of, if we're hosting it here, I may not want my neighbor who may be female to all of a sudden be able to go, I knew it, about your sexuality or something like that. So we had to balance it on both ways to go, we need to give you all the space. And at that time, as Joe mentioned, we were able to get other funding for other programs. And so we were able to sort of be very intentional on the programming. So we had something for women specifically. We had something for prison. We had something for gay men. We had something for Black gay men. We were able to sort of, divide the pie and then be able to go, look, we understand you. We hear you. Let's do it this way. And then we would all come together when we needed to. But that was one of the things that made it easier, was the programming and to be able to speak to those specific populations with someone front facing. So I could be there, but I may not say anything.
Yeah. You all, over the years, you all have proved to be very adept at that balance.
Yes, we try to.
Yes. So now let's hear from someone who has experienced this disease firsthand. Regina Beck has been living with HIV for 28 years, and she joins me now. Regina, thank you so much for being here. Welcome to This is Nashville.
Well, thank you.
Can you tell me about when you were first diagnosed with HIV?
1989.
That was the year? How'd you respond when you get the news?
I was in denial. Actually, I ended up being retested in 93. I want to say 93. And it was because a friend came to me and said that they had contracted it. And we used to share needles together when I was doing drugs. And actually, that's the year I decided I was going to do something about it, because my first diagnosis, I don't have it. I was in denial, and I didn't want to own up to it. So I become accountable in 93, and when it got tested, and that's the year I actually accepted the fact that I was HIV positive.
So what'd you do after you accepted that?
Actually, I had a bad response to it. I really didn't want to accept the diagnosis. I started back getting high. I got back on drugs. I tried to kill myself. I tried to OD. I done a lot of self-destructive things, because at that time, to be diagnosed with that, it means you was going to end up with full-blown AIDS and you were going to die. That's all the knowledge I knew, as I had of it at that time. And being ignorant to the facts, I just went through a lot of bad behaviors, and actually I got involved in some of the programs they had through CARES and through the first response and with Metropolitan, and got I got more information about living with the disease and what the medications did, and that a lot of the information about the medicines would do this and would do that, I found out were just fallacies. They weren't true. And I started actually going to the doctor, and I had a great doctor. Dr. Rafana is one of the greatest doctors here in Nashville, Tennessee. And he remained my doctor up until last year, till he retired. But to be able to get the information to know that it's okay, that you could live with HIV, and it changed my life. Actually, being infected was a blessing for me because it helped me redirect myself. And now I wanted to be more of a catalyst to help other women and other people living with HIV. After I got myself together, I say around 99 is when I started working with Street Works with Ron Crowder.
And why is it important with you to reach out and to help people in this way?
Because I know, as it was for me when I first found out about it, I took it as a death sentence, and it's not that way. You know, this disease is no different than cancer, diabetes, or some of the things that we have out here already. That if you live right, take your medicines, and change a lot of bad behavior, you can live on to, as long as you don't step out in front of a bus, you're okay. You know.
I understand you have grandbabies now.
Yeah, I have 3 grandgirls. They are my life. One's 16, one's 9, and one's 4. And I look forward to seeing them grow up and have their own children and all of that. And I make sure, like the 16-year-old, we have talks. She knows I have HIV. I feel like that you have to be open with kids today because the information, though you think it would be more plentiful now, is really not. It's still not being discussed like it should be. Well, I think it should be more aggressive behavior as far as getting the message out there, because even the older people now are still having bad behaviors that are still spreading the disease. And I can't see that happening now, but it's true.
Now, Dwayne, while we've had medical advancements to help people fight the disease, how important is it to keep people aware about the risks regarding AIDS that Regina was just talking about?
It's very, very important. And unfortunately, in the past couple of years with the COVID pandemic and everything else, people going inward and staying away from things and other individuals, it's been really challenging. It's been really, really challenging. The great thing is that the great thing and the bad thing is social media has helped a lot to try and get the word out, to try and say, like, hey, don't forget about this, don't forget about that. And education-wise, as we are coming back into getting into the normalcy, is trying to rebuild those old bridges with the high school, the colleges, and all the other places that other institutions we can get into to try and do that, because a lot of people have left. And so some people have graduated, left, or changed jobs. And so trying to reallocate ourselves to go, hey, remember we used to come out here, once a quarter or twice a semester. And so that's what the prevention team is really doing at Nashville CARES, just trying to get back out. We just got a new mobile medical unit. So we're taking all of our service out to the streets instead of waiting for them to come across one of our buildings, either at Thompson Lane or Metroplex. So it's really trying to just totally shift. What COVID did for us was to help us use our phones more, help us do some of the things. All the paper has sort of disappeared, which is great. So now it's a lot of the red tape has helped us. So the importance is to get that energy to get back out in the community to do this work, because as she said, people don't remember things, and they still continue to use agencies like ours as an emergency. So if something happens, they didn't use a condom or the condom broke, that's when they remember.
Yeah.
Oh my gosh, there's something out there.
They got to know the time is now.
Right. The time is right now.
That was Dwayne Jenkins with Nashville CARES. He was joined by Dr. Joseph Interante and Regina Beck, who has been living with HIV for 28 years. I want to thank you all for being on the show. Thank you all for the stories, and thank you for the work that you're doing. We have to take a short break. When we come back, we'll look at the current state of AIDS and how it prepared us for another pandemic. Tweet us your questions and comments at This Is Nashville. We'll be right back. I'm Khalil Ekalona, and this is Nashville. In the late 90s, Tennessee became one of the first states to criminalize HIV transmission. Suddenly, if you passed HIV to someone, you were a sex offender. Needless to say, the stigma was real for people living with HIV, and it hit our LGBTQ community especially hard. We've come a long way since then, but there's still work to do. Local artist and health educator Cynthia Harris decided to tackle this stigma with a play she wrote called The Calling is in the Body, which is based on her own experience learning about HIV in high school from a young woman named Deidre Davenport. WPLN's LaTanya Turner spoke with the playwright for today's show. One of the characters Cynthia wrote is a younger version of herself. Here's a scene from her play.
At first, the news said it was white gay men in big cities like New York or Los Angeles.
Cynthia, a character in the play, is on stage processing her uncertainties and fear about AIDS.
How can it be just one group of people? It's all so confusing and it doesn't make any sense.
The play is set in 1990, the height of the AIDS pandemic.
It was really scary at the time. We didn't know exactly what it was. We were hearing this word.
That's Cynthia Harris remembering her own experiences as a high school student at the time.
We didn't even say it. If you suspected that somebody was HIV positive or had AIDS, they might have that thing.
The play is a true story, and it's centered around Deidre Davenport, a young 20-something who had just been diagnosed with AIDS. Here's a scene from the play where Deidre tells her grandma.
How did he not care enough about us to know? Or did he know and just not tell me I had to find out by donating at a Red Cross blood drive? And what about school? What are my friends going to say?
So what are you going to do about it? Baby, no matter what happens, your body is a gift. Your force, your purpose, your calling, your power is always in your body.
It was this sage advice that inspired Deidre to speak out about her condition. Cynthia remembers meeting her when she spoke at a church youth camp.
She introduces herself and she's warm and she's personable and we're connecting because she looks like us. She's not much older than we are. She's going to TSU and we're from Nashville, so some of us are going to go there too. And then she blows our minds and tells us that she has HIV and AIDS.
She was a smart Black girl like me. How could someone like me have HIV?
You cannot tell that somebody has HIV just by looking at them. I mean, did you think I was positive when I walked in? No.
Deidre took her message about HIV and safe sex to schools, churches, and prisons. But by the young age of 27, she had died from AIDS complications. Still, her radical approach was taking off in pop culture.
She wanted people to be shocked because she wanted them to take their health very seriously. And then we get Magic Johnson in 91 coming out and saying that he's HIV positive.
First of all, let me say good after late afternoon. Because of the HIV virus that I have attained, I will have to retire from the Lakers today. I just want to say that I'm going to miss playing, and I will now become a spokesman for the HIV virus because I want people and young people to realize that they can practice safe sex. And, sometimes you're a little naive about it and you think it could never happen to you. You only thought it could happen to, other people and so on and on. And it has happened, but I'm going to deal with it, and my life will go on.
And I think that really shifted things for Black people. And then we started to see hip-hop artists talk more and more about it. We see TLC wearing condoms, on their outfits, and Salt and Pepper singing songs about let's talk about sex.
All right, let's talk about sex, baby. Sing it. Let's talk about you and sing it. Let's talk about all the good things and the bad things.
Cynthia hopes her play will continue this important work with a new generation. who no longer sees HIV/AIDS as a death sentence, who can pop one pill and prevent transmission or treat it.
The outspoken people we might hear from today, the language that we have about protection, safety, consent, all of that comes, in my mind, from this experience and from developing strategies because of HIV and AIDS.
Cynthia Harris is just one of the many folks continuing this work to get more information to eliminate the stigma. My next guests know all about this. I'd like to introduce Dr. Anita Wadhwani, the co-director of Vanderbilt University Medical Center for AIDS Research and HIV Adolescent Transition Clinic, and Dr. Brandon Jones, public relations and social media manager for Nashville CARES. Dr. Wadhwani, Brandon, thank you both for being here. Welcome to This is Nashville.
Thanks for having us.
Thank you. Dr. Wadhwani, what are some of the tools that are available today to treat HIV and AIDS?
Yeah, we've come such a tremendous way, Khalil. You know, we have gone from an era where we didn't have effective treatments for HIV. You talked about that earlier in the segment, to now we can treat almost anyone with one pill once a day. And even further, we have injectable medications now where people can be treated with an injection that lasts for 2 months. So we say now, you know, HIV truly is a chronic disease. It's a chronic, manageable disease. And if we diagnose and start treatment early, people live a full, long, healthy life.
Can you describe the typical person who you see in your clinic these days?
Well, I think it's a mixed bag. I do see patients at Vanderbilt's Comprehensive Care Clinic and also take care of people with HIV who are hospitalized at Vanderbilt. And many patients are well managed, and they come in once or twice a year, and we get routine blood work, and they take their pill once a day, and they're doing just fine. There's a smaller minority of patients who really are struggling to manage their disease, and these, I tend to see them in the hospital, either because they're coming in with a late diagnosis, and that may be driven by stigma or fear, or difficult social circumstances, concomitant substance abuse or mental illness. And so I think it's a tale of kind of two different populations. I also take care of adolescents and young adults who are a unique group who also have some different challenges with managing.
What are some of those challenges with the adolescents?
Well, you know, adolescence itself is an interesting developmental stage, right? So yes. I think we add in the idea of managing a chronic stigmatizing illness. And so many young folks are not equipped to really do that. Young people want to be like their peers. They just want to be like everyone else. And so, for instance, what I may hear is, and it may differ a little bit depending on whether they were born with HIV, so had perinatal transmission versus acquired HIV as an adolescent or young adult. But they don't want to be reminded of their disease. The clinic is a reminder of their disease. The pills are a reminder of the disease. And so adherence to medication can be really a challenge. And then we also see real drop-offs at critical times, like if a patient is transitioning from one care center to another. You know, if you're transitioning from a pediatric center to an adult center, and it's almost re-traumatizing to come and establish care with a new provider and tell your story all over again and be vulnerable all over again. And many people don't want to deal with that re-traumatization, or have, you know, just difficulty navigating the healthcare system, which as we all know is not the easiest place to navigate. So those are some of the issues.
Now, Brandon, you're not an adolescent, but you're a millennial. You're a younger adult.
Absolutely.
Did you learn much about HIV and AIDS when you were growing up?
Not at all. When I was growing up, I felt like it was like a taboo to talk about even sex within the Black community. So no.
How'd you learn about the disease?
I was introduced to the disease. I lived in Atlanta, Georgia for about 8 years, and I had people who would say negative things about other people who were living, that they were aware that were living with the disease. So things like we would be out and they would say, you know, that person has HIV or whatever, or that thing, as they would call it. And I was like, oh, really? And then I was introduced to it through a partner that I think he was unaware. So we were engaged for about 2 years. And that's when I think that I contracted it. But honestly, once I found out from someone else that he was positive, I was scared. I was fearful. Even at that time in 2018, I was fearful. And we've come so far in technology and science. So with that being said, I had to take ownership of my life. 2 years later, it took me 2 years to go get tested. And in those 2 years, I was introduced to drugs. I was introduced to all these different things. And that's kind of a way that I suppressed the feeling and suppressed the thought. And like Regina said earlier, suppressed those things. But I had to acknowledge first that this is something that you're dealing with and you need to take your health into your own hands. So I went to the doctor in Atlanta. My friends pushed me and I got into care and relocated back to Nashville, where I was introduced to Nashville CARES, and it's been history since.
So, when you talk, did you talk with your peers about this lack of awareness and how it's kind of negatively affecting the community?
Absolutely. That's something since I've been introduced to CARES that I've done. When I went to CARES, they welcomed me with open arms, and I feel like that's a place I didn't have prior to. And that love, that affection, that nurture, that sense of nurture that you get from people who do genuinely care, it's remarkable. You can't deny it. It's undeniable. And I've taken this information that I am learning as I grow with the organization that CARES, all that information and instilling it back into the community, especially in different locations where it's more prominent than others.
Why do you think it's not really being taught and exposed to younger generations? Is it still the stigma? Is it still that going on?
I absolutely think that it is it's still the stigma portion of it. I also think that you have a lot of denial of people. So you have people that are, down low. You have that are men that are down low that are messing women, and vice versa. You just have all these different things within, especially the Black and brown community, that we face. Mental health, that's something that's an overarching issue that is bigger than HIV, but it's still a thing, So I believe that that's something that we still face.
Mm-hmm.
Absolutely.
Now, point of clarity for our audience, down low is a term that describes men who are maybe in heterosexual relationships, but who are secretly having sex with men. I wonder, Dr. Ahankai, why are there still such wide disparities in managing and treating this disease, and also informing people about the nuances that go along with it?
Yeah, I think that, we can even see parallels with the COVID pandemic. We had a tremendous epidemic in the United States, and we've made definitely tremendous strides in our local epidemic. But what we see now over the past 5 to 10 years, there's been stagnant progress, and this is what happens, in a public health communicable disease like this. If you take the brakes off, if you say, that's not a problem anymore, it doesn't exist, it actually won't go away, and in fact, it will get worse. So I think that regionally, we're talking about here in Tennessee and in Nashville, the stigma is real. As Brandon said, the stigma is so real. And I was sharing with him earlier that whenever I diagnose a new patient with HIV, a new young man or woman, the conversation is about, you will be okay. You will be okay. And stigma is killing us. And whether that's people being afraid to get tested, afraid to seek care, afraid to come out about their sexuality with their family, this is leading to a lot of delays in diagnosis. So that's one real a tremendous issue. And then the disparities, HIV is not unique in this regard. We see racial and ethnic disparities across every single chronic disease there is. And so HIV is yet another one. And without looking at really specific approaches that say we are focusing on equity, we won't get rid of those disparities.
Mm.
Yeah.
Brandon, real quick, we got about 20 seconds. Have you used these similarities recognition of these similarities to really influence your peers to become more knowledgeable about HIV and AIDS?
Absolutely, which is exactly why I'm here at CARES. I took the job here because, not only because I'm HIV positive, but because I feel that people need to know that there is a place for you. There is somewhere that you can go get tested. They will introduce you to care. They will care for you, and in a confidential, complimentary way. I mean, they will do that just for you, and I think that's a big.
Brandon Jones is with Nashville CARES. He was joined by Dr. Aima Ahonkai of Vanderbilt University Medical Center. I want to thank you both for being with us today. Really appreciate it. Thank you for the work that you're doing.
Thank you.
Thank you.
We're going out today on a song by one of our guests today, Regina Beck. She says this song expresses her joy of life and details her journey.
Clap your hands. All you got to do is praise him. Clap your hands. All you got to do is praise him. Clap your hands.
We want to thank everyone who tuned in this hour. This is Nashville is a production of WPLN News and Nashville Public Radio. Listen back at thisisnashville.org or wherever you get your podcasts. Our producers are Steve Harouche, Rose Gilbert, and Magnolia McKay, and LaTanya Turner. Our digital lead is Anna Gallegos Cannon. Michaela Elias is our technical director. Our executive producer is Andrea Tudhope. Shout out to our intern, Tori Hoover, and the masterminds behind our theme music, LaRange and Namir Blade. Special thanks to Mary Owens, John Bridges, and Philip Stefeli Sewell. The conversation doesn't end here. Tweet us at This Is Nashville. Find us on Instagram and tell us what you want from our show by filling out our quick survey online. This is Nashville. I'm Khalil Ekulona. We'll see you tomorrow, everybody, and be good to each other.